by Tchaiko Parris, who is with RadNet, and she is a diagnostic and interventional breast radiologist. Well, welcome to the show. Nice to see you again. It's been a while.
It's my pleasure. Thank you for having me again.
Before we get into talking about mammograms and some things that you guys are looking for, can you tell me what the definition of your description of your title is?
So my name is Dr. Tchaiko Parris, as you stated. I'm medically trained as a physician scientist. So I have a medical degree and a PhD degree, and I'm specifically dedicated to mammography or breast imaging. And because we do diagnostic and interventional procedures, you kind of have the dual title of being a radiologist and interventional radiologist at the same time.
I see. Now, do you actually perform any surgery?
So we do minimally invasive procedures such as ultrasound-guided core biopsies, stereotactic guided core biopsies, MRI-guided core biopsies, ductograms, needle wire localizations for patients preparing for surgery. All of these procedures are performed while the patient is awake. We just do local anesthetic.
Oh, okay. Well, good. Well, I always wondered what the interventional portion of the title was, so I appreciate you telling me that. Thank you. And then let's talk about some of the things that you guys are looking for when you do have a mammogram. I mean, obviously, there are many different things that you're looking for, so maybe you can help us understand what they are.
So when a woman's mammogram is obtained, there are several things that we look for. First, we start off by assessing the breast. So for each breast, there are two views that are obtained. The craniocaudal, where the breast is placed on the detector and the compression paddle comes down. And then the medial lateral oblique, where the breast is compressed from a medial and lateral position, so to speak. So the woman would remember having her arm in the air. So what we do is that we look to make sure that the nipple is in profile. That's one. We make sure that we can see to the posterior breast tissue, and so that we can make sure that we can visualize the pectoralis muscle. And then the key thing is also to make sure that there's no motion on the film. If we lose any of these things, then the patient would get a recall for repeat imaging. The next thing that we assess is the breast tissue density. And that is where we quantitate the ratio of the glandular tissue to the fat in the breast. And then the tissue is placed into one of four categories. Either woman is fatty, she has less than 25% glandular tissue. She is scattered, she has between 25 and 50%. She's heterogeneously dense, between 50 and 75%. Or she's extremely dense, she's 75 to 100%. Once we've then quantitated the density, we then move on to assessing the pathology in the breast. So we look to see if there are little white dots that we call calcifications. We check to see if there's any distortion or pulling of the tissue. We look to see if there are any masses. At the end of that assessment, we then, because it's a screening mammogram, she either gets a BI-RAD 0, saying that the radiologist would like to do additional imaging of her breast, a category 1 saying it's completely benign, nothing is seen, or category 2, yeah, we see some calcifications or masses, but they're stable, they've been there before, no need to worry, return in 1 year.
Oh, okay. All right. Well, I didn't realize there were so many different things. Now, one thing that I, remember, of course, when I have mammograms is, the machine itself. It's been around for a while, and I know that it's had a lot of advances. What are some of the latest advances now?
So right now we have 3D mammography that's offered, and essentially for that imaging study we take multiple slices of the breast that then get reconstructed, and so it allows us to look through very thin slices to see if there are any new changes or development in the tissue. So it has a good advantage for the patients who have scattered or heterogeneously dense breast tissue. For the patients who are fatty breast tissue, you don't need that because the breast tissue shows up as dark and cancer shows up as white. So white on dark already creates a contrast. For the patients with a category 4 extremely dense breast tissue, the research studies actually shown that the sensitivity of 2D and 3D match, because at that point the woman has no fat in her breast to create contrast, and essentially it has the same sensitivity as the 2D.
So is breast size a factor in breast cancer occurrence?
Got you. So in reference to breast size, there's been shown no direct link between the size of a woman's breast and whether she's susceptible to getting breast cancer. However, the research has shown a direct link between a woman's breast tissue density and breast cancer. So because a woman would have the 4 categories of breast tissue density as I previously described, if you're category 3, heterogeneously dense, or category 4, extremely dense, it means that you have more than 50% of glandular tissue. And so small masses may get obscured. And so the radiologist may not be able to see through that tissue to find those masses when they're, less than 2 centimeters. And so the woman might then come in with a mass that's large enough that would then be seen by the radiologist, regardless of if she has dense breasts or not. So what's recommended as of 2013 in the state of California, when the dense breast law was passed, was that we now have to inform women of their breast tissue density so that they know that they may benefit from supplemental imaging, such as a screening breast ultrasound, or if she's high risk, screening breast MRI.
I see. Okay, good. Now, if a woman has a family history of breast issues, does she need to do anything differently than someone who has no family issues?
Exactly, yes, she should do things differently. So for those women, it's recommended that earlier on, as long as they can document their family history and even utilization of their own personal history, they should meet with either their primary care doctor, their OB, or even a surgical specialist, like a breast surgeon. And at that point, they would start off by doing what's called a risk assessment. This is where they would assess based on the information provided about the patient's personal history and family history, and using one of the many models out there. The most popular one right now is the IBIS model. And that's where they would get a number that is reported by the system as to the risk factor for the patient. If that patient has a greater than 20% increased lifetime risk for breast cancer, it's recommended that she should have supplemental imaging through breast MRI. If she is less than 20%, then she should have a screening breast ultrasound. Now, besides the genetic testing, besides the risk assessment, they would also do genetic testing. And that's when, through blood work or mucosal swabs, they would look to see if there are any gene mutations that are being passed on through the family line that puts this individual at risk for breast cancer. Because if there are, then once again, she should benefit from supplemental imaging.
Right. Okay. Wow. All right. Well, this is very good information. Thank you. Now, in regards to men, I'm sure they're going, oh, well, I don't need to listen to this, but they do. I mean, there are cases of men who are getting breast cancer. Tell me about that, and what are some things they need to be looking for?
Right. So there are no screening guidelines for men in the general population per se. But for men who are high risk, either have a family history or have a predisposition for breast cancer, it's recommended that they should have additional assessment. Because in men, although they have a 1 in about 800 increased lifetime risk for breast cancer, and versus women who have 1 in 8, they still are at risk, as you stated. So it's recommended for these men who are high risk that they should have clinical breast exams performed semi-annually by their clinicians starting at age 35. That male should also be doing self-breast exams like women once a month. And it's recommended that they actually should start off with a screening mammogram at age 40 to get a baseline if they have a strong family history. And that's because, just like women, yes, age is a factor in the relationship of men getting breast cancer, but also hormonal use. So men take medications, and some of these medications can actually lead to changes or elevations in the estrogen level within the body. Also, men who are obese are also at risk, and men who have liver disease, such as cirrhosis of the liver or any type of liver dysfunction, because the liver catabolizes or breaks down estrogen for excretion, if the liver is not functioning properly, then once again, it will build up in the system. So for men who have a family history for breast cancer, it's actually recommended that they should get monitored just like a high-risk woman.
Wow, great information. And so now at least we can say, all right, men, you need to listen as well, because this is something, even though the ratio isn't quite as high as a woman's, they still need to be concerned. So great information. Nice to see you again, doctor. I appreciate you taking the time.
No, thank you for inviting me once again. It was my pleasure.
All right. You have a great day, and we'll talk to you again.
Thank you. Likewise.
All right. And we'll be right back after this.